All right, we're going to carry on with the rest of Travis.
Unrelated question was, is there a difference between accelerated junctional rhythm and junctional tachycardia?
No. So either one of those is a correct answer.
It was the rate. I had an understanding that like 60 to 100 was accelerated junctional, and then over 100 is junctional tachycardia.
Anything above the pacing, inherent pacing for the heart, or for that particular part of the pacing area, would be either accelerated junctional or junctional tach. So regardless of which one you put, if you identified it correctly as junctional tach or accelerated junctional rhythm, you're okay. And as a matter of fact, the key that I'm going to send out will have two things. One, it'll have the correct name of the rhythm, and on that one specifically, I've gotten written accelerated junctional rhythm or junctional tachycardia. If you had a rhythm, so for example, like you had on like number two, no, not number two, number four. Number four, the correct name is normal sinus rhythm with PVCs, so you get all the credit. If you were to identify that as normal sinus rhythm with unifocal PVCs or normal sinus rhythm with bigeminal PVCs, you get extra credit. And on the key that I'll send out to you, the extra credit name will be in parentheses right next to the right next to the required name. So, anybody else? All right, so let's finish up with acute coronary syndrome today, and because what I want to do on Monday is to get into CVA, strokes. Now, we're thinking, well, this is a cardiology class. Why are we talking about strokes? Well, this is actually a cardiovascular class, and because strokes are caused by the mess up of the vasculature of the brain, then we include CVAs or strokes in this particular module. We go in deeper with it in advanced cardiology. And there's a lot of similarities between patients that have strokes as far as their pathophysiology and patients that have heart attacks. So let's talk about angina. Angina pectoris, more commonly we just call it angina, comes about as a result of a deficiency of oxygenated blood that's getting to the heart. That leads to which one of the I words that we talked about in here? Ischemia or infarction? That leads to ischemia. And so our patient begins to have discomfort, pain, different other types of symptoms along with that, because the heart cells that are distal or beyond where that partial blockage is now do not have particularly enough oxygen, but they also don't have enough glucose, because remember, the body needs oxygen and glucose in order to have correct metabolism. And so there's a failure on the part of the blood to have enough that's getting beyond that. If it's 100% blockage and there's no blood going through, then we wind up with infarction or necrosis, death of tissue. We can save tissue when it is ischemic based on what we're going to be talking about in just the next few minutes. Generally, what we're looking at here is the bullet says it's brought on by exercise or other stress. The better way to put this is angina comes about when the demand for oxygen is not met by the supply of oxygen. There's some oxygen that's coming through, so some of the cells are still being able to be to have effective metabolism, have good oxygenation and perfusion, but not all of them, and so they begin to suffer. Okay, and so there is some processes that go on here prior to the death of those. Angina itself is almost always relieved by one or both of these: rest and or the use of nitroglycerin. Now, we'll talk about nitroglycerin in just a little while. how it works, and why it is so very important. Yes?
Can you use aspirin too?
Aspirin is going to be used as a treatment when when we're taking care of any patient that has chest pain, chest discomfort as a result of what we would diagnose as a cardiac origin. But aspirin itself does not relieve the pain, but it is part of the treatment. And when we talk about treatment for angina and MIs in just a minute, aspirin is going to be a key component, and it's actually going to be, if not the first, the second drug that you're going to give in this particular situation. Good question. There's two types of angina, okay? One is stable, one is unstable. What's the difference? Stable angina can be predicted by the patient, okay? Either the onset or the relief, or both. What do I mean by that? Let's say that you've got a patient that comes into this building. Let's say they're coming here and they decide they're going to go back out and they're going up these stairs. Let's say the elevator's out of operation and the only way out of the building is upstairs. So if it is a stable angina, the patient may know, James, that I can climb up to that very first landing and then I'm going to have a little bit of discomfort. I'm going to get short of breath, may get a little weak. But if I sit there for 30 seconds, 60 seconds, that law and supply demand of demand from the heart for oxygen and the supply of oxygenated blood by the heart equalizes out. That goes away. I can go up another flight of stairs. So in that situation, the patient can predict this is what's going to cause it. The other part of that is they can predict what's going to treat it. So they know I get up here and I sit and I stand or I wait and it goes away. Or you get up here and now I know that it's the kind of angina that I have that I really need to take a nitroglycerin. So I pop in a nitroglycerin, I wait 5 minutes or so, pain has gone away, and now I can go on about my day. So if the onset or the treatment result is predictable by the patient, it's stable. It's not progressing. Unstable angina, on the other hand, it obviously is different. Two of the things that we see here is that something changes with the onset and or the treatment. Now, there'll be a third part that'll come up here in just a minute. Same patient. They walk up the stairs, and now, rather, Travis, than getting to that first landing of stairs, and they know they're going to have some chest discomfort, they only get about 6 steps up, and now the discomfort is there. They stop for a minute, and it goes away in the same amount of time. But predicting the onset has changed. And now that becomes unstable angina. That tells the patient, hopefully, that the blockage that they have has become more severe. Because now, instead of going up one full flight of stairs, they can only go up 6 steps, and now they begin to have a discomfort. Or, let's say that the patient climbs the steps, goes up, gets that first landing. Yep, there it is. I'm having a little bit of discomfort, a little shortness of breath, some weakness, maybe a little shortness of breathing. And I wait. And instead of a minute, now it takes 3 minutes or 4 minutes for that to go away. Or I have to take a nitroglycerin, whereas I didn't have to take it before. Or maybe now instead of one nitroglycerin, one doesn't fix it. Now I got to take 2. Okay? So, and we'll talk about the dosing regimen for nitro in a minute. That's your unstable angina. Something has changed about being able to predict the onset as well as the relief by the patient. It's an indication that the blockage has gotten worse. Third type of angina, this is scary, will be angina that awakens the patient from their sleep. Think about it. When we're in bed, we're horizontal, so we're not having to work against gravity to increase that workload of the heart. We're resting, we're sleeping. You can't be in a more calm state than when you're in a deep sleep. Patients will often awaken with that same chest pain, that same discomfort, shortness of breath, maybe a little bit of weakness, and it scares them. It's awakened them from their sleep. They dial 911, and James, you get there, and by the time you get there, they go, I don't know why I called you. It's all gone now. I sat up, and in about 3 minutes, it went completely away. Or I got up and I took a nitroglycerin, and now it's all gone. I'm better now. I feel good. You got to convince that patient to go to the hospital, because that's a major change. Because again, Travis, we can't be more at rest than when we're asleep. Something has happened to that blockage that has made it severe enough that the oxygen demand is greater while they're asleep than what can be supplied. And so usually they'll take a nitro, it'll open up that artery somewhat, and they'll get some more blood going through. And so that would be examples of the pathophysiology of stable versus unstable. Now, I will tell you on your final exam, I'm going to give you some scenarios, and I'm going to ask you to identify, is this stable angina or unstable angina based on the patient's presentation. So I want to stop there for just a minute. Make sure that is all nice and clear with everybody. Any questions about the differentiation between the two, the pathophysiology, signs and symptoms, or the treatment?
Unstable angina is unpredictable.
Either the onset is unpredictable or the relief is unpredictable, or both. Yes. Anybody else? All right. Make sure you got that right there in the front part of your brain where you can access it really, really quickly. So, moving on from angina to acute myocardial infarction, heart attack. Okay. This happens when the artery that is feeding a particular part of the heart. And remember, what are the two arteries that I told you needed to know that branch off of the aorta? There you go. And again, they will branch into even further, kind of like you go out here on the interstate and then you get off onto 25, and then 25 will branch off onto side streets, and then you get out in the country and it'll branch off further into a gravel road. Arteries in the heart do the exact same thing. When there is a blockage and blood cannot get through, the tissue, the cells that are distal or beyond where that blockage is, begin to die. We call that infarction or necrosis. That first bullet says that it's usually described as heavy pressure squeezing. It can run the entire gamut. I've had patients say, well, I feel like I get a little burning in my chest. I think it's heartburn. True story, guys. True story. 2 years ago, and I may have shared this with you, and if I have, I apologize because I'm old and forgetful. But I was teaching advanced cardiology upstairs, and my chest started burning. I thought, man, I ate something bad for breakfast. And it kept burning, it kept burning, it kept burning. And I finally realized I was having a heart attack while I was teaching cardiology. Go imagine that. So anyway, I had Hillary drive me up to the hospital. I'm very grateful for her to help me and take care of me. And I got up there and I had a 100% blockage of the right coronary artery. Okay, so none of the right side of the heart was really getting any blood, and it was all because I thought I had indigestion. So again, look at your patient, look at their demographics. Typically, we're looking at somebody in middle age or older. Not always. I've taken care of some patients that were in their 30s that had heart disease. And take all of the symptomology that we'll talk about here in just a little bit into consideration. This pain or discomfort that they have can go anywhere. It can go to one or both of the shoulders. It can go up into the neck. It can go into the back. Okay, and we're looking at that. Here's a thing to keep in mind. Many times patients that are having an MI have this impending sense of doom. They will look at you and Catherine and they'll say, I'm going to die, aren't I? When a patient asks you that, take it seriously. Okay? Again, true story. When I worked in Knoxville, I had 3 patients. I worked for a rural metro down there, which is now owned by AMR. 3 of these patients, when I was down there, I was transported into the hospital. Chest pain, MI, identified it on the monitor, and they looked at me and they said something to the effect of, I feel like I'm going to die, or I'm going to die, aren't I? And when a patient asks you that question, be honest with them. Don't tell them nobody dies in the back of my ambulance. Well, that's a bunch of garbage. People die in the back of ambulances every single day. But tell them, well, it's my opinion you're having a heart attack, but I promise you I will give you the very best care that I possibly can. We're going to get you to the hospital as quickly and safely as we can. Of those 3 patients that looked at me and said, I feel like I'm going to die, all 3 died either before or after they got to the hospital. Why do they feel like that? Because the heart is not working as a good pump, which means we're not getting blood to the brain. That is a type of severe anxiety. And anxiety in the MI patient and in the trauma patient is a sign of shock. That is a type of altered mental status. When you get into advanced trauma, we'll discuss this even deeper because, again, anxiety can be simply because, oh man, I'm having a heart attack. I don't want to die. I have a wife and kids. I want to stay. I want to stay alive. So that fear could just simply be there, or it literally could be because of this. But when the patient has this sense of impending doom, that's anxiety raised to the nth level. So take them seriously. The sympathetic nervous system can begin to go into overload, which means the heart rate goes up. Why is the heart rate going up in an MI patient a bad thing? Yeah, it puts more stress on the heart. It increases the workload. The best first thing that you all can do as paramedics is to be competent, compassionate healthcare providers. That'll serve you for a couple of purposes. Number 1, it'll keep you out of trouble. Okay. Number 2, being competent and compassionate is always good for public relations. But number 3, and the most important reason, is, James, it's the start of good medicine. If I'm having a heart attack and you come in and you show me you know what you're talking about, I'm a layperson. It's kind of like, okay, I will know whether you're competent or not if you're calm and collected. Inside your brain, you may be running around saying, what do I do? What do I do? What do I do? But out here, you've got it all together. And if you know what you're doing and you express compassion to your patient, guess what's going to happen? That sympathetic nervous system is going to go from here down to here, which means heart rate is going to drop, blood pressure is going to drop, respiratory rate is going to drop. The amount of adrenaline from fear is going to drop. And why do I say that is the start of good medicine? It's because every one of those is the goal that we want to do for a patient that's having a heart attack. We want to reduce the workload on the heart. So as Catherine said, heart rate up puts more stress on the heart. Adrenaline up because I'm fearful for my life puts more stress on the heart. But if you come in and I see that you're interested in me as a person, and at least you appear to know what you're doing, now my sympathetic nervous system begins to relax. Parasympathetic nervous system kicks over. And now you have already started treating that MI. Now, there are some atypical or unusual symptoms that we will see. Primarily, and I want you to burn this into your brain. We see it somewhat in the in the elderly, but we most definitely see it in females and diabetics. And we've kind of already talked about this a little bit. But for females and diabetics, rather than having having a complaint of chest pain, nausea and vomiting, diaphoresis, their only complaint may be a sudden onset of unexplained fatigue. They may say, an hour ago I was fine. I was sweeping the house. I was playing with the kids. I was unloading groceries. I sat down here, and 15 minutes ago now I'm so tired I can't raise my arms. Okay? And I think I told those of you that were here on Monday the story about a student who ran a call. I think it was over in Estill County, actually. And they had a 45-year-old female whose chief complaint was fatigue and nausea. And the student said, I heard you on my shoulder saying, females, they don't play fair. They have MIs that have different symptoms. They did a 12-lead EKG on her. She's having a massive MI. She went into cardiac arrest on the way to the hospital. They resuscitated her, and today she's back home with her family. And that's the key I want you to do, is to be aggressive in looking for this in both diabetics and females. Why do diabetics not feel chest pain the way non-diabetics do? Well, it's probably because of diabetic neuropathy. Keep in mind that diabetics who do not have good control of their blood sugar, the nerve endings begin to dissolve, and that's how we feel pain. That's how we feel pain in our chest when we're having a heart attack. That's how we feel pain in our head when we're having a stroke. But those nerve endings have dissolved, and they can't feel that pain. For females, I'll be quite honest, they really don't know why yet. Ladies, you have just unexplained fatigue. But again, that's the key here, is unexplained fatigue that you need to know in that regard. Other cardiovascular emergencies that you need to... Yes, sir.
On that last slide, it says sudden onset of unusual SOB. What does that mean?
Shortness of breath. We tend to not use that because it generally means something entirely different. And I need to get in there and edit that. I put these slides together a long time ago when it was appropriate to use it. But shortness of breath, sometimes you'll see it called SOA. It's not Sons of Anarchy. It's shortness of air. Difficulty breathing, dyspnea, just all those mean the same thing. Good question. Anybody else? Other cardiac emergencies. Remember, we talked about first of all, let me ask you a question. What's the precipitating cause of cardiovascular disease? Inflammation. Awesome. Inflammation. When inflammation gets so bad and the inner lining of the artery begins to pull away or delaminate away from the muscular part of the artery, blood begins to collect up in there. We see this a lot in patients that have uncontrolled hypertension, and they can live with this for a very long time. This is why hypertension is known as the silent killer, because you can have high blood pressure and your first symptom is cardiac arrest. But in an aortic dissection or an aneurysm, and these all come about from the same pathophysiology. When this lining of the artery pulls away from the muscular part of the artery, now blood begins to pack in there, and it continues to pack in there. And if a patient has uncontrolled hypertension, now it gets in there under pressure. In essence, what happens here is that, as you can see with the laser pointer right here, we begin to get a pouch that develops, okay? So you can see this part right here, that pink part is the muscular part, or the tunica what? Media. And the black lining out here is the tunica adventitia. Good. And the white lining in here is the tunica intima. Outstanding. Good. And so as it comes in here, it begins to develop and it begins to pack and it begins to push out. Eventually, what happens is it's kind of like in the old days, long before you were born, and probably when your parents were children, we had tires that had inner tubes in them, and they would begin to develop a weak spot. And that tire would begin, instead of being nice and round and circular, it would have kind of like a bump on the outside. That's where air had collected between the lining of the tire. Eventually, if that is not corrected and it gets serious enough, that will rupture. Depending upon the size of the rupture and where it occurs is a indicator of how serious that will be. If you have an aneurysm in your brain that ruptures, that leads to a type of a stroke. We'll talk about that next week. If you have an aneurysm of the aorta, remember the aorta is the largest artery in the body, comes up off the heart, goes down through the chest, down in through the abdomen, bifurcates at the pelvis, down into the femoral arteries. As it comes off your heart, it's about the size of your thumb. If that opens up and ruptures either up here in the chest or down here in the abdominal area, many times your patients go into cardiac arrest immediately and there is no saving them. Okay, they just simply bleed out so very quickly. So what are some of the things that we're looking at? Well, again, the presentation or your patient's signs and symptoms, much of it depends upon where it's at, whether it's in the head is where we're really concerned, or if it's in the chest or the abdomen. For right now, we're going to talk about chest and abdomen, all right? Next week, when we talk about strokes, we'll talk about it in the brain. Your signs and symptoms that you will most commonly hear patients say is, man, it feels like there's something just kind of tearing in my chest, Sydney, or down in my abdomen. I just feel like that there's a tearing pain, which in essence is exactly what's happening. If this is the muscular layer and this is the tunica media, this is the tunica intima, if we're doing this, literally, we're tearing the artery apart. So that's a good way of them to describe it. Sometimes these patients will say, well, it hurts right here in my chest. It's kind of this tearing sensation, and it's going to my back, especially up into my shoulders. Or down here in my abdomen, it's tearing, and it's going up into one or both of my shoulders. The other thing that we can look at here is that when we get blood pressures on our patients, if you suspect that your patient is having a thoracic or an abdominal aneurysm, and a thoracic aneurysm is just called that. Sometimes we call an abdominal aneurysm a triple A, abdominal aortic aneurysm, triple A. You check our blood pressures, and you will have a normal blood pressure over here, and then you will either have a higher or a lower blood pressure in the other arm. Drastically different. When you check blood pressures, they should be relatively the same. They won't be exact, but they should be relatively the same. The other thing that you may see in these patients, and this depends upon the size of your patient, is that especially if it is a large abdominal aortic aneurysm, you may, if they're lying flat, you may see this mass in their stomach up here under the skin, just pulsating like this. Think of all the alien movies that you've seen where the alien just kind of comes out of the belly of the host or whatever it is. And that's the way that it always helped me to remember. Now, here's the thing. That's a rare sign. I've seen that one time in my career. One time. But you're not going to see that in all patients. If I were to have a AAA, abdominal aortic aneurysm, I'm a big guy. You're not going to see that. I've got lots of adipose tissue. Those of you that are a small stature or that are muscular, it's much more likely to be seen on someone of your size. If you see that, don't palpate it. Think of it like a water balloon. If we push on a water balloon, they have a tendency to rupture and to burst. If we push on that palpating mass, we may cause it to burst, and then we have what's called a PAD, paramedic assisted death. Not good. Not good. Okay? So you can't let these patients walk. You got to put them on a stretcher. You got to keep them calm. You got to help them to relax. Again, maintaining your own calmness. And then you would transport them to the hospital. In advanced cardiology, we'll talk more about what you can do as a treatment. But I want to stop there for just a minute. Any questions regarding aortic dissections?
The bulge in the back too.
The bulge will move to the back, but typically the back is much more muscular on all of us, so you won't see anything in the back. Mm-hmm. Good question. Good question. Anybody else? Heart failure. Now, you will hear medics of my age and my generation refer to this on a regular basis as congestive heart failure. The terminology is changing now because, as we'll talk about in just a minute, where does that word congestive come from? In heart failure, we don't always see that, quote, congestion. We'll talk about that in just a minute, also known as pulmonary edema. But congestive heart failure comes about when the heart itself is too weak to act as a forward pump. Basically, the heart, particularly it starts out, the most common cause of heart failure is an MI. And it causes the left ventricle to begin to fail. And when the left ventricle begins to fail, blood begins to back up. It will back up first into the left atria. Then it will begin to back up into the lungs. That's where the pulmonary edema comes from. We have two types of heart failure, okay? I'm not going to get real deep into this because we'll take a huge deep dive because I'm very interested in this in advanced cardiology. You have left-sided heart failure. You have right-sided heart failure. We'll talk more about the whys of those in the sequence. Left-sided heart failure, let me back up. Signs and symptoms for both sides, left-sided and right-sided, are typically going to be difficulty breathing, chest pain, weakness, a blood pressure that is elevated, okay? The differentiation that I want you to know at this point in your educational career between left-sided and right-sided heart failure is in left-sided heart failure, you will almost always hear crackles. Now, we've talked about crackles in here. What are crackles?
Just the fluid built up in the lungs.
Thick fluid or thin? Thin. You had a 50-50 chance. It's okay. You got the most important part of it correct. So it is thin fluid. Remember, I like food, obviously. Remember, crackle sounds like when you're done with lunch today, you got a cup of your soft drink or your tea and it's full of ice and you're trying to get that last little drip through your straw. That's the same sound as crackles. That is fluid. Primarily, what part of the fluid of the blood? Plasma. That's the plasma that has been pushed back into the alveoli. Now, ladies and gentlemen, I believe you all are smart people. I love being around smart people. Why is fluid in the alveoli a bad thing? Say it again. Say it like you mean it. There you go. There's no oxygen exchange. Not only is there no oxygen exchange, there's no carbon dioxide exchange either. Both of those have to happen in order for us to live. A gas and a liquid cannot occupy the same space at the same time. That's about all I know about physics, okay? So when we get fluid in the lungs, excuse me, also known as pulmonary edema, we begin to hear those crackles, okay? That, for right now, is your hallmark symptom of left-sided heart failure. You'll still have chest pain. You'll still have weakness. You'll still have difficulty breathing, but you can have that for both left and or right. So what happens in right-sided heart failure? Well, the right ventricle begins to fail. Anybody have a clue as to the most common cause of right-sided heart failure?
Is that do something with the valve? Take that down.
You're really, really close. Think about it. Anybody else? The most common cause of right-sided heart failure, left-sided heart failure. The heart is not working. The left ventricle is not working. So that means it falls back over onto the right side of the heart. Again, we'll get deeper into that pathophysiology and advanced cardiology. And then over a period of time, the right ventricle begins to fail. Yes, sir. Absolutely. So think about it this way. Remember, left side of the heart fails, the blood will typically back up, and it ultimately backs up where? In the lungs. Yeah, in the lungs. When the right side of the heart fails and it backs up into the right atria, where is the next place for it to go? Because it's not going to the lungs in that direction. It's going to go up into the neck and down into the lower extremities, okay? We call that, down in the lower extremities, we call that pedal edema, P-E-D-A-L. Boy, my southern accent just came out. Pedal edema. Pedal having to do with the lower part of the lower extremities. Do you have a question?
Yes. Whenever you do like I guess you could say palpate or like the capillary you feel on the legs, like would it come back? Would it?
Keep going.
Sorry, would it stay?
Don't apologize. You.
I guess would it come back white as you would like with the fluid being?
No.
No.
No, it would not, because you got all that fluid there. But here's the other finding that you will find. Later on today, I want you to go palpate your own leg first. If you're going to palpate somebody else's leg, make sure you have permission, okay? Because I don't want paperwork coming back and say, hey, Dr. Young said I can touch your leg. Don't do that. Take your thumb, push it in, and let it out. In about 2 seconds or less, that dimple that you caused from where you pushed in should fill completely back in, okay? If it takes 3 seconds or longer to fill back in, we call that pitting, P-I-T-T-I-N-G, edema. We've caused a pit in the leg, and that's because what we've done is we've displaced all that fluid that is in the lower extremity, and it's taking it longer for it to come back in. And generally we call that 2+ or 3+ or 4+ pitting edema. That's how many seconds it takes for that divot that you've put in the lower extremity to fill back in. That's a significant finding. The other thing that we'll see, just like you said a minute ago, is that we will often see jugular vein distension. The veins, the jugular veins, when we put our patient at about a 45-degree angle, will now begin to engorge and to swell up and to bulge. Now, you will occasionally find people that are really muscular, and I would dare say some of you, primarily males that are in here, if we put you at a 45-degree angle, your jugular veins would distend as well. But that's not because you have heart failure. That's just simply because you have well-defined musculature of the neck. In this situation, though, what we would see is that blood is backing up in there. So again, I will give you some scenarios, and I will say, define and tell me left-sided heart failure, right-sided heart failure, or both, because you can have both, okay? As far as treatment of those, we'll get into that a little bit later on in the semester, what little semester we've got left, but definitely we'll take a deep dive when we get into advanced cardiology. Questions about heart? Well, let me back up. The congestive part, you can have right-sided heart failure by itself and your breath sounds be completely clear. That's why they've done away pretty much with the congestive heart failure or the CHF part. You will hear, like I said, people of my generation, my age, still calling it CHF, okay? Just be patient with us. We're going to die out, and you all will you can make your own changes then. But if you hear it CHF, okay, you know. Okay, I know exactly what's going on here, all right? Questions about heart failure?
Would there be any contraindications for giving epi for cardiac arrest?
No. There are no contraindications, not even an allergy to epi. How can I be so sure that you cannot be allergic to epi? Say it again? It's found in the body, except in the body, we call it what? Adrenaline. So yeah, no contraindications. And we'll do a little bit of pharmacology, maybe next week, but definitely the following week. Pulmonary or cardiogenic shock. Cardiogenic shock occurs again when the heart cannot pump enough blood to perfuse the body. This is often seen after an MI. The big difference between cardiogenic shock and left-sided heart failure is that your patient is literally in this word right here, shock. With heart failure, heart rate will often be up, but so will your blood pressure. In cardiogenic shock, your heart rate will go up, but your blood pressure will begin to fall. These are the symptoms that you're looking at here as far as cardiogenic shock. Early on, heart rate will go up. Blood pressure may maintain a good pressure or may even be a little bit higher. But over time, as that left ventricle continues to weaken, the heart rate will continue to go up and the blood pressure will continue to fall in that regard. They can have a really fast heart rate, especially early on in cardiogenic shock. And if we're not able to fix it, they will eventually convert into a bradycardic rhythm. Why? Why will they go from, Travis, why will they go from a really fast heart rate to a slow heart rate?
First they're compensating and then they're not able to.
Yep, you're exactly right. Awesome. So they're compensating, okay? The heart is pumping, and then eventually the heart just gives out. And it starts slowing down, and they go into cardiac arrest. They can be restless and anxious. Why are they restless? Why are they anxious? What did I say that was called? What is anxiety called? What causes it in this situation? Like a perfusion where? To the brain. Okay, restlessness, anxiety, anxiousness, altered mental status. Altered mental statuses are caused by poor perfusion to the brain. Not enough oxygen, not enough glucose, all right? The skin will get pale and cool. Remember, the shock process is the body tries to perfuse the big three organs. What are the big three? Not the brain, heart, and lungs. The brain, the heart, the kidneys. The kidneys. The lungs don't need a huge amount of perfusion because they've got lots and lots of vasculature in there. And their primary purpose is to pick up oxygen. The kidneys are critically important for us to maintain our acidity versus alkalinity basis, also known as pH. So the heart will, in this order, and you'll hear me refer to this until you leave this program, the big three: brain first, heart second, kidneys third. When perfusion begins to shunt away, regardless of the cause of shock, whether it's cardiogenic shock or because your guy's been shot in the stomach and he's bleeding out from a lacerated liver and spleen, blood begins to get shunted away from the extremities first, from the skin first, to move it into the core of the body. Then it begins to get shunted away from the kidneys. Why is that important? A lot of y'all are going to be working in an ER. One of the first things you're going to do when a patient comes in shock, you're going to put a Foley catheter in. Why are we so concerned about how much urine's in the bladder? Because when the kidneys shut down, they begin to stop making urine. That gives us early warning. Our patient is not doing well. Then it will begin to shunt it away from the heart, and then lastly from the brain. Okay? And that doesn't take much of a shunt away from the brain to, again, lead to an altered mental status, most commonly called anxiety or restlessness. Here's the other thing. We'll talk about that later. Okay, so that's cardiogenic shock. All right, questions about that as far as the pathophysiology? Pulmonary embolism. Pulmonary embolism. And embolism is what? We kind of talked about this a little bit. What is an embolism? Yeah, it's any kind of a blockage or a clot. It can be caused by mucus. It can be caused by blood. If it is, then it's a thrombus. It can be caused by air. Here's the other thing. You'll learn this again later. A lady who has a baby can have some of the amniotic fluid after her delivery get into her bloodstream and cause her to have a pulmonary embolism, a blockage, because of that, not calcified, but it's not really clotted, but because of the amniotic fluid that gets in there and blocks off the artery. So basically what we're looking at here is we see a clot. Most commonly it comes either from the legs or from the heart that gets into the vasculature that feeds the lungs. And what happens then is that artery gets blocked off, okay? And it can cause rapid difficulty breathing. You'll still have equal and bilateral breath sounds. You can have really sharp chest pain, a sudden onset of chest pain. Your heart rate will go up. The blood pressure will begin to drop because this is causing a type of shock. It's called obstructive shock. Your patient shows all those signs and symptoms of shock. You know what one of the most common causes of a pulmonary embolism or a blood clot going to the brain is? That's important for you all to know in here. You actually saw it on your quiz today. Say it again? That can lead to it, especially if it's coming from the legs, atrial fibrillation. Okay? In atrial fibrillation, the atria is just kind of quivering there, got a bunch of impulses, and it's not completely ejecting all of the blood out of the atria. What does blood have a tendency to do when it sits? It clots. And so our patient can, what is known as, throw a clot. And that can travel. It can either cause an MI, it can cause a stroke, or it can go to the lungs and cause a pulmonary embolism. Other things that you might see with this patient is that you can have a sudden cardiac arrest. Your patient is fine, and now they are dead. Also, you may see what is known as the pulmonary embolism, or the PE cape. From the nipple line up, your patient's skin looks like a Smurf. It is purple, okay? And that's all of the venous blood that's beginning to back up and to pool. And it happens in just a matter of a few minutes, okay? We're not going to talk about any of the treatment of these at this point. We will talk, but with the exception of MI and stroke, we'll talk about some treatment there. Any questions on a pulmonary embolism or a PE? Hypertensive emergencies, really high blood pressure. Generally, anything over 130, over 90, over 3 consecutive weeks or longer. Okay. When we have a patient that goes into hypertensive crisis, then you get blood pressures that are higher than what you see there. I have seen patients with blood pressures as high as 250 over 160. The bad thing about that is that if they survive that, generally they have destroyed their kidneys and they will almost always have to go on dialysis. Okay. The big thing that we're going to see with patients with severe hypertensive crisis and emergency, headache, unilateral weakness, okay? That's weakness on one side of the body or the other. Many times they'll say, I can't focus, or especially on one side of my visual field. Anybody in here ever had migraines? Okay, so you know exactly what I'm talking about when you say, it looks blurry and kind of over in here. I can see fine over here, but it's blurry over in here. So we again, that's early recognition is really important. What we want to do is we want to educate our patients to keep them from getting into this situation. If that pressure continues to go up, they can actually have a seizure because they're not getting enough blood going to the brain. Questions on that? All right. Patient care. Basically, overall, what we're looking for is we're going to look to see, is our patient sick, not sick, or not yet sick? Okay. We look at our patient and we go, well, I think our patient's okay in this regard, but I'm going to watch them closely. Okay. These are the things that you want to really watch for and assess closely. In your assessment, you want to identify what's their respirations? How fast are they? Are they normal tidal volume? Tidal volume is the amount of air we normally take in and exhale in one breath. Is it a normal tidal volume or is it shallow tidal volume? Another homework assignment for you. Don't be creepy about this, but I want you to start watching people breathe. Okay? Please don't let public safety come over and say, hey, we got Travis over here and he's watching people breathe. Can you tell him not? So I'm picking on you. So just kind of watch people breathe. And that's the way you learn what a normal tidal volume will be. So we're looking for rate, tidal volume, and rhythm. Is it regular or is it irregular? Same way with a pulse. We're looking for rate, rhythm, and regularity. Something we've already learned in here with our EKGs. Our mental status. Remember, mental status is one of the earliest identifiers that we can see as paramedics that we've got shocky systems going on. We have to differentiate, is it, especially in trauma, is it because a 16-year-old just took his dad's brand new truck out and wrapped around a telephone pole, but he didn't have permission because he's afraid of his dad? Or does he have an aortic tear because of chest trauma and he's leaking blood out? Look at our skin. Skin is the largest organ of the body. It will give you a ton of information. We look for color. We look for temperature. And we look for condition. Is it sweaty, diaphoretic? Is it clammy? Okay, is it kind of that yucky, cool, wet sensation? Look at your patient and see how they're positioned. If you got a patient that has heart failure, quite often they may be leaning over like this in what's known as a tripod position, with their hands on their knees and leaning forward to try to breathe. So look at that position. Make sure you know this slide as well as this one also. Getting your patient's history is critically important. And we do that history by what's known as an OPQRST mnemonic. O is onset. Well, tell me what you were doing when the pain started. P, provocation or palliation. PALLIATION. Provocation or palliation. Provocation is if you do something, is it make the pain worse? Or if you do something or stop doing something, palliation, does it make it better? Okay. Quality. Can you tell me what it feels like? That's the question that you want to ask. Radiates. Where does it start? And can you tell me, does it go anywhere else? Does it go into your shoulder, to your back, your neck, down in your legs? Severity. Have them identify with 1 being absolutely, positively no pain, and 10 being the worst pain of your entire life. What does it rank on that scale of 1 to 10? And then time. When did this start? Did it start an hour ago? Did it start 2 hours ago? Or whatever? That's where I'm going to stop. Next week, when we come back, we'll talk about stroke.